Thank you, Gaia. But I think it provides a very comprehensive overview of some of the capacity development issues, and especially as they pertain to the IHR. Also, just one additional piece of information with regards to that first interagency guidance that we developed with WHO and IFRC. CDC and USAID also were part of the process of looking at some of the content issues and provided very, very helpful inputs. So for us, that was a very important step moving forward as a more coordinated effort. Over to you, Erma.
I have all these dynamic speakers, and then I'm the last speaker of the day. Well, okay, let's get started. I'd like to look at this issue of the systems perspective from a country level experience based upon my work as the head of community engagement for UNMIR during the Ebola crisis, and the work I've been doing more recently with the in polio as we deal with vaccine-derived polio outbreaks. So I will be focusing on 4 areas, talking about, again, coordination mechanisms, but hopefully a different angle of what we've been discussing already. The whole concept of preparedness to detect and respond to outbreaks, and what are we looking at in terms of capacity. Thinking about building that capacity in a limited resource environment, and ultimately to talk about what are some of the bottlenecks that we are experiencing in the field. And I'd like to frame that in 4 different dimensions. One, again, looking at leadership and coordination and looking more closely at what that entails. Dealing with the aspect of technical capacity and technical guidance, improving data and strategic information systems, and increasing institutional resources. And by that, I mean governmental resources as well as other institutions that may be in a particular country. Just to put in context, Ebola, and just as a reminder, is when we've been talking about risk communication, we have to understand that at the time of Ebola, we were really looking at that in the context of community engagement and behavior change, but it was only one of 4 pillars. And we've spent a lot of time yesterday and today looking at the risk communication component of that, but what we didn't talk about is how that particular component interacts with all the other 3. Any particular type of outbreak or emergency, there are other dimensions that are going on, and we have to look at what is that interface between risk communication and some of the other technical areas that may be operating. So I'd like to look a bit closer at the social mobilization and communication community engagement pillar, because it was probably the first time in an emergency that there was actually a pillar, coming together as a cluster of partners in a way that we hadn't seen before. And I'd like to also look at that in the context of the Global Polio Eradication Initiative, which kind of set the foundation for what we saw in Ebola. So if you just think about how this pillar actually worked in the field, you had at the national level, the partners, the UN agencies, the NGOs, civil society, led by the Ministry of Health. But what was interesting in Ebola was other ministries were involved. And one of them that was really critical was the Ministry of Finance. Normally in risk communication, you wouldn't have seen that particular ministry, but that was the one, if they could see the investment case, can move the monies within the government system. So although there were a number of partners who were on board, and this pillar probably in every country was the largest pillar, I think in Liberia there were like 100 partners trying to meet. And these pillars were meeting weekly, planning, strategizing, trying to look at what is the best way forward. We talked on the mind map that Raphael showed us. They talked about timeliness, they talked about transparency. Well, beyond coordination, what these pillars did was look at trust among the partners. We always talk about trust with the partners and what we're doing and the community, but there were issues of trust and transparency between the partners themselves. Based upon their funding, how they were doing things, people had their own approach to risk communication. So these pillars, when they did their job well, and Reverend Sumo is one of the better ones, really got a chance to exchange with each other what they were trying to do, how they were trying to do it, so there was a better understanding of the collective perception of good and a way forward. So not only was it important at national level, but the key was making it work at district and subnational level. That's where the energy really needed to be to drive what was going on in terms of Ebola. So on the one hand, you had a whole pillar. They're thinking about messaging. They're thinking about materials development. But another key component of this particular working group was their work around interpersonal communication, their engagement with people. We had a similar process in the Global Polio Eradication Initiative, primarily led by the national government. And I put in blue the 4 key partners supported by Bill and Melinda Gates Foundation, and of course having other partners that are meeting on a regular basis. But what Ebola did was that regular meeting, not only within the pillar, but across the pillar. And it was the first time that risk communication was sitting with the epidemiologists, sitting with the clinicians, strategically planning what will be the intervention. Enhancing technical capacity and systematizing the technical guidance. On the mind map, timeliness was an issue. And one of the things that struggled in Ebola was getting people out to work to support the government, to just get people to agree to take the decision to be a part of a team to go out. So that raised the whole issue, as Gaia was saying, a surge capacity. But it isn't just international surge capacity. It's not just regional surge capacity. It's also national surge capacity. And what we saw in a number of the countries during Ebola, they began using practitioners from other sectors. Teachers who were not in school became people who were working on risk communication. People from the water sector were working on risk communication. So the opening up of what we mean by surge and at what level are we really talking about it becomes extremely important when we're talking about enhancing the technical capacity. I can't emphasize enough the leadership at the government level at this particular point. Because to be frank, if you think about the 3 countries in Ebola, it really depended on who was sitting in the government level leading this. You saw Reverend Sumo. It didn't look like that in Guinea, and it didn't necessarily look like that in Sierra Leone, given who was there. So there's some issues when we talk about capacity building of working with the government to try to figure out who, given their skills and competencies, and how can we support them, and to what extent the partners have to take the lead or not, even though technically you will see that the government is the leader. In some cases, actually, it was the partner who helped them do that. The other aspect that became really important, I think, during Ebola, and that we've also seen in the polio work, is the importance of academic and corporate partnership. There was a tendency for the technical expertise to come from outside, forgetting that they were academic institutions in country, there were anthropologists in country, and people were flying them in. So we had some issues of the homegrown anthropologists saying, wait a minute, I've been here 30 years. I've been here 20 years doing this work. You fly in for 2 weeks, get your information, go back out and write a journal article. What's going on here? So there was tension, and even within that particular community, although they saw the need for their work to bring it forward. National Comprehensive Capacity Development Plan, critical. And by that, I mean not just frontline workers, but thinking about supervisors and the managers. Those are the people who are watching this, overseeing, guiding. And we've heard from Gaia the point about decision makers and policy makers. that has tended to be the group that is least addressed. But if you think about a comprehensive capacity development plan, pre-outbreak, then you're going to be thinking about these particular groups and how you might want to approach them. So in the frontline worker training, which is where a lot of the NGOs put their energies, it freed up some of the other partners to begin thinking about working with decision makers, policy makers, and working with the managers and the supervisors themselves. But the question I want to ask you is, who is the risk communicator here? Because our tendency has been, and a lot of our discussion has been, thinking about the health people, the people with the label that says I'm a social mobilizer or I'm a risk communicator. And in fact, what we realized in Ebola were all these people, the safe burial teams, the case managers at the ETUs, the contract tasters, they were all risk communication people too, because they were engaging in communities. And what we were seeing is oftentimes what the social mobilizers, what the journalists and communications people were having to deal with were backlashes from what the other groups were doing. So when we're talking about the whole issue of risk communication, we have to move beyond just the health, the people with the health label. Same thing we saw going on in polio. Initially, the whole focus was how do we strengthen the skills and capacities of social mobilizers? And then we began understanding that you had to talk about health officers. You had to talk about health managers or the polio manager, and even more so just the vaccinator, because they were first contact. The other aspect, and Gaia mentioned it and Reverend Sumo mentioned it, the importance of standard operating procedures. And not only having the procedures, not only having the guidelines, but doing the preparedness training ahead of time. One of the complaints I always heard in the field was, we get all these great ideas coming in. All I just want somebody to do is give me the thing I'm supposed to be doing. I don't want to have a theoretical discussion. I just want to know, what are you expecting me to do at this point in time? And that's why the SOPs become extremely important. And it's good to hear with the IHR now, they're coming out. We did not have them from Ebola. What we do have them for polio. And then there's training that goes with it, not only at frontline worker level, but for the managers and the supervisors. There's briefing documents put together for the policymakers to give people the tools that they need. In addition to that, there's the online support. There's Rizomi. You talked about the one you're doing from WHO. There is a technical advisory group who not only looks at what the countries have come up with in their terms of their preparedness plans, but they review it. They give feedback on it. Countries have to present. They have to defend their strategies and why they're trying to do it. So it becomes an operational movement forward to try to take the work and the planning that people are doing. Polio has been really good, and I think it has offered to Ebola, and it has implications for Zika on the micro planning. They have been extremely strong at planning at a micro level, of working with those partners at the closest to the community to strategize, adapt and modify whatever needs to happen to reflect that particular community. We can learn from that experience. It's clearly detailed out. It's a matter of just sharing it. They have put together a global communications toolkit that talks 4 manuals that talks an individual through, a team through what they need to do during an outbreak. And what's interesting is they made a delineation that seems to be holding up for other disease outbreaks in terms of how to even think about risk communication within a 24-hour and 14-day time period. Which part of the house is leading at which point in time around different kinds of activities? Because one of the things that we saw in Ebola was the communications people, as they're doing the media, were going one direction. The communication for development, community engagement people were going through another way, and they were fighting. who's in charge. What this allowed people to begin to do is to see there is a role for both. One may take a lead at a certain period of time, but they're working in tandem with each other. So it took away a lot of the internal friction within the risk communication continuum itself among the practitioners. One of the things that we've talked about yesterday that became important, and I just highlighted here because I think polio has been really good at doing independent monitoring while the outbreak is going on, bringing in people who are watching what others are doing, trying to deliver service and giving feedback. The other piece that they've done is outbreak assessments, when they bring in that external body to look at what has happened and to provide feedback back to the country. You've already talked a lot about the anthropologists, the social science networks, and researchers. Again, I would just make the emphasis of how we need to engage the national uh, um, researchers in this process. Community monitoring was critical in Ebola, and I think it's one of the key things that did really well when you just use mobile telephone technology. They don't necessarily are using Twitter, but everybody seemed to have a mobile phone, and you ask a question, did you see any miking today? And people click back and give you an answer. And then you ask them another question, have you heard of any secret barrels? And you capture this data over time so that you can strategize and adapt your programming. A very important tool, but it's bringing the community on board at the same time. Increasing institutional resources, private sector. One of the reasons we were able to do a lot of the mobile technology, telephone technology, is because we got the telecoms involved. And they were allowing people to have access to the service without paying. So there are ways you can bring monies into governments that may not have the money themselves. I think we have to look at how can we converge with other programs going on in ministries that are related to health, not health directed. So education is trying to open up schools. The water and sanitation are trying to change water sites. There are ways in which they can work together. There are ongoing programs, so now we see a lot of work, at least on the polio side, linking back to immunization and just child health in general, to use some of those. And finally, looking at what communities themselves are willing to offer once they understand what's available. And we saw a lot in Ebola where communities were helping build, at times, ETUs because they thought it would do certain kinds of things, or they were willing to allow people to do certain things in their communities, and they provided that, the government didn't. Last point. What are the bottlenecks, or what I call the catch-22s? Lack of consistent policy direction and guidance. So yes, you may have SOPs. One of the big problems is the staff turnover at senior level. So today you have somebody in who believes in what's going on, they support it. Tomorrow you get somebody else. Same thing in the US, same thing in Europe, and it goes away. The other issue that we've run across all of, I think, the interventions is this tendency to top off salaries to the point that people don't see it as their job. They see it as if they don't get money, they don't do that piece. They'll go over here and do this little tiny piece that they were sitting there. So the perception is, as partners have gone in during these outbreaks, during these interventions, we're topping off salaries so they get paid to do something extra, rather than seeing it as a part of their ongoing work. The other area has been not only the staff turnover, but demotivation, people not getting paid. So they've got the skills, they got the capacities, and they haven't been paid in 3 months. And yet we're going to go ask them to do X, Y, and Z. In many of the ministries, the health promotion department is probably the weakest one. And in most of the government systems, the Ministry of Health, like the Ministry of Education, are the weakest ministries. So we've got an issue of how do we position this discussion with finance, with planning, to make an investment case of what it costs them if they don't do something, if they don't release some of the funds. And the last point I just highlight is our tendency has been in all of these efforts to talk about community volunteers and to get concerned when they want to get paid. but there's no virgin communities anymore. So everybody's seen everybody else come in and get monies for the work that they're trying to do. And yet we're saying, we want you just to kind of come out and do it on behalf of the community. I'll stop there because I think there's some issues we need to talk about.